Good afternoon, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are Oncology Brothers. Today, we're joined by a renowned practicing medical oncologist who focuses on treating GI malignancies. He's the director of GI Oncology program at the Interlakes Healthcare program in Utah. He's also a big social media influencer with more than 70,000 followers on multiple different platforms. In our brief discussion, we're hoping that Dr. Mark Lewis will share his thoughts on a few clinically relevant studies that were presented at ASCO and how this would shape our community practice. Without further ado, let's welcome Dr. Mark Lewis.
Oh, thank you so much for having me. I'm an only child growing up. I always wanted to have siblings, and now I get to hang out with the Oncology Brothers. But more importantly, this was a big meeting. ASCO 22 is one that we'll remember as practice changing in a variety of respects, and specifically, as we'll talk about, it had implications for GI oncology.
Perfect. To dive into our discussion here, Mark, we'll be spending just a few minutes on each of the three studies. One focusing in the adjuvant space using the circulating tumor DNA, the other one in neoadjuvant space, MSI high rectal cancer patients, and then the plenary paradigm study. Our goal with this is to keep generalists informed and spark an interest in the practice-changing studies so that we can continue to ensure we are providing the best available standard of care options to all our patients. So let's get right into it.
Perfect. So we'll get started with the first study that was interesting and caught our interest, and I think is very clinically relevant. This is, again, an adjuvant space for stage 2 colon cancer.
Yeah, and obviously his background, for almost 2 decades now, with the Mosaic and the Quasar studies as sort of the primary foundation, we've struggled, like you said. We don't want to undertreat particularly the high risk, prognostically unfavorable stage 2 colon cancers, nor do we want to overtreat in, as we're all aware, potentially cause irreversible side effects in patients who may never have needed chemo in the first place. So this is what I call the trolley problem. It's medical ethics made real, where we really are trying to find that balance. So this study was fascinating. This study, as you can see from the schema on the left, again, high-end New England Journal paper here, was a interesting randomization. So it was a 2-to-1 randomization weighted towards a biomarker-driven group. And as you can see there was a post-op ctDNA measurement roughly about 2 months after surgery that was then used to guide the selection or not of adjuvant chemotherapy, versus the other arm of the randomization was standard management. So using our traditional clinico-pathologic criteria and our judgment as medical oncologists. And the high-level takeaway is that there was zero difference, as you can see in the graph, the Kaplan-Meier on the bottom right. There was zero difference in recurrence-free survival between standard and ctDNA-guided management. So a couple things I'll say here. One of which is I find this actually quite validating. And what I mean by that is, for a long time, I have sort of learned to respect T4 disease. To me, a patient with high-risk stage 2 colon cancer, T4N0, might be as prognostically unfavorable or worse than a low-risk T3N1 stage 3 cancer. And in fact, this study to me proves a point, which is that our traditional TNM classification system, I think, really underestimates the potential risk posed by high-risk stage 2. So that's one takeaway. The other takeaway is that if you do the final analysis and actually look at the numbers, while the relative amount of chemotherapy given in the biomarker group was less, the overall amount of oxaliplatin in particular that was administered in the ctDNA-guided group was higher than in the standard management group. So I saw this occasionally inaccurately described as an opportunity to give less chemo. I think the better way of putting it is giving chemo in a more discriminating fashion to the patients who are more likely to benefit from it. And what that means is, again, trying to refine our aim so we're not undertreating, we're not overtreating. It's sort of the Goldilocks effect. We're trying to get it just right. And the last thing I want to say is I don't think this is specific to this particular ctDNA assay. I think this is a larger evidence of, if you have MRD, if you have minimal residual disease in a solid tumor like colon cancer, you can use that signal, and ideally its disappearance, to both prove the benefit of adjuvant chemotherapy and also hopefully the clearance of micrometastases through treatment.
Would that differ if the ctDNA was to be negative in stage 2 high-risk setting?
Yeah, this was a real takeaway, and you can see there actually the sort of relative risk plotting of the T3s versus the T4s. You can see that there is a trend towards less chemotherapy use with ctDNA-guided management in T4s. However, there was a lot of consternation about this, and people saying, you know what, I'm not ready to jettison the offering of adjuvant chemotherapy to my T4s, even if the ctDNA signal is negative. And I thought that was interesting. What we really need is larger prospective trials in this space. There's one that's going to be absolutely massive, which is Circulate US. It's also going to be known as NRG GI 008. And I think enrollment on a study like that is actually probably the path forward. I think there's still a lot of medical oncologists who look at this data, say this is wonderful. I am still not ready to take the risk of undertreating my T4s.
Perfect. Thank you for that. We can now jump on to our next study.
PD-L1 blockade in MSI high patients, locally advanced rectal cancer patients. So please, stage is all yours, Mark.
Yeah, absolutely. I mean, this was both amazing, but almost to the point that we need to, I think, curb our enthusiasm just a touch. I'm not trying to be a wet blanket. I still think this is incredible. You know, there was a concurrent publication in the New York Times of this study, and it's not often you see, you know, a phase 2 with a sample size like this get that level of mainstream coverage. So I think a couple of takeaway points for me here. Number one is this was single agent anti-PD-1, and specifically it was dostarlimab. And what I'm getting at there is, while that's wonderful for this particular drug, my personal sense, and I think a lot of us feel this way, is this is probably a class effect. You might have seen the same result, for instance, had you used pembrolizumab. So I'm not entirely sure it's specific to this drug. In fact, I'm almost certain it's not. Secondly, you know, some people have said, well, should we really be surprised by this? So, you know, one of the massive landmark changes in GI oncology in the last several years was Keynote 177, showing that we can use pembrolizumab as a chemo-free approach to stage 4 colorectal cancer. Now, I admit the response rates in that trial were not what we see here. A lot of people kind of start to wave their hands and invoke a different microenvironment and different sort of infiltrating lymphocytes in the rectum versus the colon. But regardless, this is an amazing, amazing study. What I really think an oncologist in general practice should take away is we should not be missing the opportunity to test our rectal cancer patients for mismatch repair deficiency. If there's no other takeaway here, I think that's it. Because similarly, with Keynote 177, we are under testing our colorectal cancer patients, and we'll really drill into that with our third study in a minute. But honestly, this is an opportunity now with the pathologist to get as much data out of, you know, your colonoscopy specimen, for instance, as possible. You do not want to miss the opportunity to treat your patient in this fashion. And as you can see what happened with the schema, they were actually planning on going on to chemoradiation and going on to surgery, but everybody had a clinical complete response, which gave them this sort of nice problem to have. So, you know, we don't often actually attend these meetings with our pathologists, but both from this study and a host of other studies at ASCO, including Destiny Breast 04, my takeaway was it has never been more important to work in lockstep with your pathologist, and at the very least, make sure you're ordering the tests that will guide this kind of management.
Mark, thank you for bringing that point up. And not just in colon cancer, not just in breast cancer. I believe that in community, we are.
And I presented a study at ASCO GI this year, again, not to sort of grandstand it, 1/3 of metastatic colorectal cancer patients were not even getting tested for MSI, which means that 1/3 were potentially missing the opportunity for treatment with pembrolizumab, which is, again, just kind of mind-boggling. So, you know, these advances are wonderful, but we have to make sure that we are, again, testing the appropriate amount of patients to match the patient to the treatment.
Now let's jump into our last study, the paradigm study. This is presented at plenary, and here we're looking at metastatic disease in colon cancer with your VEGF inhibitors versus EGFR inhibitors.
Yeah, so I'll point out that it was fascinating to see this particular study at plenary, and as we may say in just a minute, I don't know if the takeaway is this trial in particular, but more how we should be thinking about our colorectal cancer patients. So regardless, so this study was trying to answer the question of which biologic is best. So although this was a study run in Japan, I think it actually reflected a lot of common US practice where many of us will reach in the first-line metastatic setting for FOLFOX as the backbone. And then the question has long been, well, what do you put on top of that? And the reason this is so confusing is all of these different trials. The first one that comes to mind is CLGB 80405, a trial that at first had curves that looked completely on top of one another, superimposed, irrespective of which biologic you were using. But then things got really interesting when you started to consider sidedness. And this was really one of the first analyses that showed, oh my goodness, you really need to be thinking about EGFR-directed therapy for your left-sided tumors, and you should not be thinking about it at all for your right-sided tumors. So I'm leading up to here is when you select the left-sided population, and there was some kind of sophisticated statistical analysis in the schema that we're going to get into, but when you select the left-sided population, there does appear to be a modest but important survival advantage if you pick EGFR-directed therapy with FOLFOX as your first-line approach. And there's some interesting things happening with the curves, as I think you can see on the bottom right, and in fact even on the middle right, there's some crossing of the curves, perhaps suggesting some non-proportional hazards or some sort of interaction with time of treatment. But regardless, a lot of people looked at this and said, well, this actually tells me that I should be using EGFR-directed therapy first, and then I can always come back to it later should I need it. Whereas if you start with bevacizumab, that may be a survival benefit that you never gain back. And one analysis is if you go with bev first, you may be sacrificing something like 3 to 4 months of your patient's median overall survival. I'll also point out there was a landmark here, a very important one, where we saw median overall survival in the panitumumab group exceed 3 years. So this is an important reference point. We actually should be celebrating that. We've seldom seen actually that kind of median overall survival in the first-line metastatic colorectal cancer setting. So that actually I thought was wonderful. But maybe the best part of this presentation, I think maybe we have a slide on it, was the discussion by Dr. Cremolini, an amazing and incredibly articulate oncologist from Italy. And she did a superb job because she took Paradigm and situated it in the larger context. And I think this is going to echo the message from our prior study where just like no oncologist who's treating breast cancer would dream of treating without knowing ER, PR, or HER2, I think what Dr. Cremolini said and is showing us here is there's a minimum amount of data that you need to make treatment decisions for your metastatic colorectal cancer patients, including MSS, but also knowing extended RAS, knowing BRAF, and arguably even knowing HER2. And what she did that was so elegant is she took Paradigm and again sort of added it to this flowchart that's in front of you. So I immediately sort of grabbed this slide and thought this is a treatment algorithm that I can use in my practice, that many of us can use in our practices, but it is all predicated on knowing these biomarkers. And so this finally prompts the pragmatic question of, well, how much time should you be taking upfront to get these results? In truth, like we said earlier, if we partner with our pathologists appropriately, we ought to be able to get these results in just a matter of weeks. So there shouldn't be considerable delay in being able to kind of figure out which avenue our patients are going down. But what Dr. Cremolini sort of landed on was if the primary tumor is left-sided, if it's RAS and BRAF wild type, and if it's microsatellite stable, then she would choose.
Yes, thank you so much, Mark, for taking time to discuss these practice-changing trials with us today and dissecting this information in this ever-changing field.
My pleasure. And listen, it was a huge meeting. And most of all, as you've seen, it's already stimulated such excitement for our patients. I have to tell you, this was a great week for me to come back to clinic. I'm super busy. I'm sure you guys feel the same. But the sense of the field having just literally moved forward in front of our eyes, it's galvanizing, and our patients feel it too.